All right. Well, hi, everybody. My name is Jordyn Watts. I'm the Chief Resident of the Emergency Medicine Program here at Freeman. Today, we're going to be talking about airway management. This would have been kind of a better lecture to do at the beginning of your series, because I'm sure you've gotten quite a bit of content that you'll see today throughout your other lectures. I'm going to talk to the girl that does the scheduling, which happens to be myself, about this next time. But the algorithm starts with A, right? So airway management is kind of the bread and butter of what we do. You guys also met my husband the other day, Jordyn Watts, who did difficult airways. And so next year, we'll not only try to do this one first, but we'll do them in order so that it makes a little bit more sense. But hopefully a lot of this is some review for you guys, and maybe you'll learn something new today or something helpful. And so that's kind of the goal. So let's jump into it. You guys know me. You met my husband. These are my co-residents here. The Jets actually won a game last night, so you guys probably know a little bit about me. You've probably seen this slide. Yeah, they actually won last night. It was a miracle. I actually turned it off at half. It was so bad. But we got a new friend in our house. This is Benny. I'm going to have to bring him by to meet you guys because he's just an absolute love. But that's just a little bit about me. But hopefully you guys know me. This is my third year doing this. I just wanted to clarify some of the content, my husband's slides the other day. Semantically, if we break this down, he has inferred that I am the airway manager. So these are like dinner time conversations. And we were going back and forth about Mac versus Miller, who's the real airway manager, EM providers or anesthesia providers. But anyway, if you break this down semantically, he in fact did call me the airway manager by saying this. So don't tell him I said that, you guys. Right. So here's some of the content we're going to cover today. We'll go through some background stuff, basic airway anatomy. We'll touch briefly on difficult airway stuff, but you guys got a whole lecture on that. Non-invasive airway techniques, intubation, surgical airways, transitions of care, and just some interesting studies and numbers kind of throughout the presentation, just to kind of back up what we know and what we don't know about EMS and airway stuff. So airway management is obviously one of the most important aspects of pre-hospital care. It's critical to patient survival, and it affects the potential for recovery from emergent illness or injury. And this also kind of encompasses ventilation assistance to promote oxygenation and might include protecting against aspiration. So it's really important to what we do. Historically, intratracheal intubation has been considered the gold standard for airway management. However, the primary objective in the pre-hospital setting is to assure ventilation of the patient until the transfer of care to the emergency department happens. Options for airway management include many different levels of invasiveness and complexity that require a lot of different techniques and experience. So the simplest of approaches are part of just like a general first aid, where like we talk about a head tilt chin lift versus like, the use of drugs and surgical techniques, right? And so the first endotracheal intubation performed in the field was actually done in the 70s by a paramedic out in Pittsburgh. John Moore was his name. And since then, airway management in the field has really become a foundation of care in the pre-hospital setting. So what you guys do is really important. So now there's definitely like very little debate regarding the importance of the airway, but the questions remain that have to do with the optimal approach by doing so. And so then I posed the question, like, why does it matter if the patient survived? Like, why does it matter which way we went when we picked an airway technique? But the core dilemma in the pre-hospital care is to match the airway management technique with the needs of the patient and the resources that we have available by selecting the one that's most likely to produce the best patient outcomes. Always considering the patient needs and resources includes taking into account their condition, so the type and severity of their illness, the location or environment, like safety, distance to the ED, mode of transportation, and the available equipment and personnel. So like what kind of technologies do we have? Who's on our bus? What kind of expertise do they have in this? EMS agencies are increasingly part of larger healthcare systems, and there's a protocol being developed with and medical direction alone is now required for all levels of pre-hospital personnel. And the most seriously ill or injured patients seen in the ED arrive through EMS. So this is the most important skill you guys are going to have. When we think about the guideline developers and the EMS system leaders, they want to use this data and research to address the core dilemma. Many are striving to develop recommendations that are evidence-based in an environment of expanding options for pre-hospital airway management. And so we have these evidence-based guidelines, and we need to establish a standardized approach to airway management. And that's what we try to do, right? That's what our local efforts are all about. In 2024, you'll see some numbers here on the screen. This was from August of 2024 with Ohio State. So don't come from you non-Ohio State fans, but this was a good study. They did an extensive records review, and they basically looked at 440,000 cases. They compared airway techniques and how the trends change over the years. They found that intubation attempts started to go down as we started to use more supraglottic attempts. So those were increasing. And they said it was the first formal study to make that recommendation. So here's a bit of some of the numbers that you can see here. This was pretty good evidence for how to optimize patient airways in many instances. So your ET attempts went down to 55.1% and your supraglottics went up to 61. And this is actually one of the first formal studies that confirms that. So it's kind of interesting. So this was another.
I'm supposed to tell you that Dr. Morgan is listening.
Oh, hi, Dr. Morgan. This was a study that compares airway techniques by the Agency for Healthcare Research and Quality. They did this from 2019 to 2021. So still pretty recent stuff, but they wanted to look at the evidence available to support the development of evidence-based recommendations, again, for pre-hospital airway and assigning recommendations to the key questions that you guys see on the screen. So they wanted to compare the benefit and harms across the airway approaches, so like BVM, supraglottic airways, and intubations with or without RSIs. And then the key questions evaluated the three factors, including patient characteristics, injuries and environment, techniques, devices, and then the characteristics of the personnel doing all of these things. And what they found was by applying these like low, moderate, high, or insufficient evidence to each of these, they compare the techniques under the criteria, right? So what did they conclude? Let's get to the good stuff. Well, they didn't actually. They didn't give us anything substantial in terms of recommendations, which is kind of the point that I'm trying to tell you, because EMS research in regards to airway management is actually really lacking. And when you go to give this lecture and you want to pull up some good numbers for all of this, I can't. And so I want to argue that this is just kind of confusing. But my point is that it's very patient-based and they can't pull up any specific recommendations based on what we've got here. So how do we evaluate our patient first? Let's get into it. Let's pretend like this isn't the last lecture in your series, because again, assessing a patient's airway is like the first thing that you do. We always emphasize the importance of starting with ABC, but this includes looking, listening, feeling, and giving you a really good idea of the status of your patient. So one of the easiest and best ways to evaluate for airway patency, easy peasy, ask for their name, ask them what happened, make them vocalize something to you. Evaluation of the ABCs is going to allow you to make really smart decisions based on the patient's clinical conditions. Although there are many things that we use in the hospital to determine a patient's respiratory status, like blood gases, chest x-rays, all that kind of stuff, you don't want to delay when you suspect compromise of the airway. And you guys don't have that. So you have to make a really good decision on whether or not you need airway support. So if they're in need of an airway, don't go past that step until you've secured one. Don't delay in any means. One of the first things you'll want to do is assess for signs of obstruction, and these can be functional or mechanical obstructions that we talk about. Functional being more things like an unconscious patient, and mechanical being more like a foreign body. And so there's so many different ways that you can classify obstructions, like upper, lower, partial, complete, acute, chronic. And does it change what you do? Yeah, it could. An acute mechanical obstruction, like a foreign body in a kid, is going to be managed differently than, like a chronic elderly man with an esophageal tumor. Your importance for the airway stays the same, but the art of the physical exam should not be lost on anybody, and this is absolutely not a job for AI. And so keep that in mind. It's always important to take a second or two just to ask yourself, why doesn't the patient have an airway? What am I finding on my exam? And are there specific techniques that I should be using to address that? So just some really, really basic anatomy. These are some of the important structures of the upper airway. We're talking about everything basically above the vocal cords within the larynx, right? It's important for a lot of reasons when you think about how some of our airway techniques are applied and how they work. And I'm not going to kind of go into like a specific anatomy lecture, but when you're applying an OPA or an NPA or a supraglottic airway or even an ET tube, it's important to know what kind of structures you're looking for, what kind of things could be causing resistance, and some causes of maybe some upper airway obstructions, right? Like tonsils and adenoids, tonsillitis, macroglossia, a large tongue. Like keeping these things in mind can be important. That's all part of your upper airway structures. And then you've got lower airway structures, so everything below the vocal cords and some things that can cause lower airway compromise, including like masses in the upper chest, thermal injuries, smoke inhalation, hemorrhages, all kinds of stuff. But this is just like a basic idea and a basic overview. So we've evaluated our patient. What's the rest of the stepwise process, right? Like this is how I go over it in my head when I'm preparing for an airway. And these kinds of things are specific to not just intubations, right? Like it's important to apply these kinds of steps and basic processes. So even when you're going to do any kind of airway, we've done all the first part, but now we prepare for the airway. So this doesn't just apply, like I said, to intubations. It applies to any technique. So, like, does my patient need pre-oxygenation? Do we apply a nasal cannula? Do we use the BVM? Do we use a non-rebreather? This is where the algorithm might stop, because maybe that's all that they need and they seem to be perking up with one of those things. But if I'm pre-oxygenating prior to an intubation or prior to a surgical airway, like these things can actually improve outcomes for patients. And so this step is not one that you really want to miss. And sometimes, like I said, the algorithm ends and that's fine. Maybe all they needed was a non-rebreather before they got to the hospital. So as a bonus question, like, why do we pre-oxygenate patients, right? Like, what's the mechanism behind it? And if you guys don't know out there, we do this to maximize the amount of oxygen in the lungs, primarily in terms of their functional residual capacity, which is kind of what's left in the lungs after we breathe, in order to delay hypoxia. So many times you'll hear it described as like a nitrogen washout, where we kind of exhale the rest of that nitrogen and give room for the oxygen coming in. Meds. So like, why do I ask about meds? Do you need to RSI a patient? Do you need to give some Ativan or something to calm them down when they're using their BiPAP or their CPAP? Do we need to give Zofran? There's obviously a lot of meds, and choosing the right ones for like a sedative and a paralytic can be a whole separate lecture in and of itself. But it's an important thing to consider. And then your actual procedure portion, whatever the application of the device may be, sits here, right? So applying the NPA, the OPA, the supraglottic, knowing how to use the devices is something that we'll cover here in the next few slides. That's like the most important content. But if you don't know how to use them, then you're going to be in trouble. So, and then finally, after the procedure, always go back and reassess your patient. I teach ATLS too. So when you have students kind of testing out, oh yeah, A, B, C, D, E, it's all great. And then, you change something and then they keep going. And I'm like, no. You have to go all the way back to A and do it again. And that's kind of the same concept. Like, once you change something, once you notice a difference, every time you reassess your patient, you're going back through ABCs all over again. And then maintenance, if you guys have a long transport or whatever it is en route, even if it's across town, doing the same techniques, like bagging every 6 to 8 seconds, keeping the patient on the nasal cannula, making sure that they're still stable. Do we need to make any changes to our vents or our BiPAP, CPAP machines? And this is we're like driving as fast as we can when they're really sick part. So, find what's working and keep doing it. And then finally, transition of care to the ED team. We'll kind of talk a little bit about this at the end, but let's move on to the next slide. So this is kind of just is all of that in just like a picture, especially when I have like excited students in the department. I'm always willing to let them do an airway, but you better have a plan A, B, C, and D, right? Like my plan A was to maybe throw in an OPA and bag, but what if that's not working? Or what if my intubation attempt was unsuccessful? What's your next plan, right? If my OPA bag technique's not working, I'm like, hey, I need to intubate this person. Well, if that doesn't work, what are you going to do next, right? Like, what's your next step? So I always want to know that you guys have like a thought process in your head, like, and maybe it goes from, the OPA in the bag to the intubation to the supraglottic, and to whatever else it could be, like using a video glide scope, whatever you guys carry. But it's just important to kind of have this stepwise approach in your head and prepared for the next step. So, okay, now we're going to talk about these in kind of a stepwise fashion. We're going to start with the most basic stuff, like first aid type stuff, and things that should not be overlooked when we're practicing airway management. And then we'll go into some more advanced stuff. So the head tilt chin lift, like I said, this is under basic first aid. They teach this to just first responders on the street, people in their jobs, like corporate jobs know how to do this hypothetically. But you don't want to overlook this. This could potentially open a patient's airway and allow them to breathe. Obviously, we're not doing this in patients that have concern for a cervical spine injury, but you're just extending the neck, taking the index and middle fingers, lifting the mandible, because it lifts the tongue from the posterior pharynx and can improve airway patency almost immediately. So this is not a move that you want to overlook. I still do this next one, the head tilt chin lift jaw thrust, when I'm getting ready to intubate a patient. I've got respiratory there, I've got other hands that are helping me bag, and I'm opening the airway by doing this head tilt chin lift jaw thrust in the appropriate case, right? Again, not in patients for cervical spine injuries, but this allows the tongue to move forward with the mandible and removes it from the back of the throat, opening the airway again. You kind of take the heels of both of your hands, put them on the sides of the head, the parieto-occipital areas, pushing that mandible forward to move the tongue forward. And again, in this diagram, you can see that they're kind of doing both, which is how I go to bag my patients before intubation. It allows for better pre-oxygenation. And so these are very basic techniques, but they're super important and we can't overlook them. And of course, there's more, right? Like we've been talking about these cervical spine injuries. When I'm going to immobilize somebody, it's important to talk about the topic because it can change your airway management and some of the maneuvers that you do going forward. The majority of airway maneuvers do involve some manipulation of the cervical spine, so you want to be super careful when you suspect an injury. Failure to do so obviously can result in a 7 to 10-fold increase in neurologic injury, which is significant. Obviously you'd have to have a ton of extra hands to do some of this stuff, and that's not always the the case. But applying a cervical collar is kind of the most common way in EMS that you would tackle something like this. Inline stabilization is something that you see them doing here without the collar. And so if you do have extra hands, it allows for a little bit more manipulation of the jaw if you do have somebody that can help you. And typically, if you're going to do airway management, you're probably going to do the one that's labeled D on the right side of your screen. So that way you can work from the top doing it airway stuff instead of the other way. But any questions about any of those maneuvers? If not, they'll let me know. But we'll move on to non-invasive airway management and some supraglottic techniques in the meantime. First, we talk about the NPA. This is one of the easiest devices to use when used properly. It's a soft, hollow rubber tube, obviously. We pass it into the posterior pharynx through the nostril. These are tolerated by patients, more so in the oral version, especially in your awake population. And so consider using it because it allows to keep that patency of the airway present. The sizes of these are based on, if anybody doesn't know, its internal diameter. So the larger the diameter of the NPA, the longer the tube, and the more open it is. So you want to choose a tube that's based on length to improve the accuracy of placement. Typically in adults, normal large adults, we do an 8 to 9 centimeter tube, and then 7 to 8 for medium, 6 to 7 for smaller adults, measuring from the corner of the mandible to the tip of the nose with the flared end at the tip of the nose. Use lube on these. If any of you military people out there, you probably put these in each other when you did your medic training. It's extremely unpleasant even with the lube, so don't be afraid. Blood is lube, spit is lube is lube, use it. It's very uncomfortable, especially if your patient's awake and needs one of these. And then obviously I'm a picture girl, so you guys can see how it kind of just like fits into the nose and sits down into the posterior pharynx, okay? I like to visualize it so I understand when I'm putting it in where I'm trying to direct the tube. And you want the bevel side facing the midline so that it doesn't scratch along that mucosa. If I hit resistance, I do 2 different things with these devices. The first is I try to rotate it as I'm trying to advance it. However, if it continues, obviously you don't want to shove it in there. There's probably a reason that you can't, and that's why we have backup methods. Some of the concerns that we have with these NPAs is obviously disruption of the basilar skull. And if I'm concerned for significant facial trauma, I'm probably not putting it in there. Improper insertion, angling it towards the skull. If you feel like you can't get it in, just twist it like I was saying. Too long of a device means it can go into the esophagus because it'll just kind of pass down past the larynx. So you got to be careful you're measuring properly. And then injury to the nasal mucosa causes bleeding in about 30% of insertions. So that's why I say lube it up and make sure you're putting it in the right way to kind of avoid some of those complications. All right, your oral pharyngeal airway. These are your patients that are deeply unresponsive. They don't have a gag reflex. So we can put these in. I like to put these in underneath my BVM. And so that way I've confirmed that I've got an open airway while I'm bagging. It's a curved, firm, hollow tube with a rectangular piece to maintain a conduit between the mouth and the glottis. For sizing, they're done pretty similarly, except for going at the posterior angle of the mandible to the corner of the mouth, mirroring the path that it's going to lay in the mouth. And then the 2 major ways to put this in, the most common way that we kind of teach is putting it in basically upside down and then flipping it 180 degrees and then rotating it back like to sit along the tongue, right? So like the curve sits on the tongue. The other way is that you can use a tongue depressor and kind of like pull the tongue out of the way, stick it in there, put the tongue back. I think the first method's kind of easy. It requires less equipment. It's easy to just slip in. A few important things is you always want to make sure it's in there correctly. Obviously, if you're having problems ventilating, like I said, stick one in there, then use your BVM. It might be too small. It might not be positioned right. Always try to troubleshoot your device before you just yank it out and try something else. And then hazards include pushing the tongue back, using too small of a device, which piggybacks on what I was just saying, and then catching the tongue or the lip in between the device or the teeth or whatever, and then using it with an intact airway. Obviously, we don't want to be doing that. So we want to take it out right away. Okay, oxygen delivery devices. This is actually one of the most commonly prescribed drugs in the emergency department, and you guys know that too. This kind of translates into what you do. We put oxygen on a lot of people. And so it includes a variety of devices that deliver oxygen to continuously, spontaneously breathing patients or those that are not spontaneously breathing. And factors that influence these decisions in which device to use include mainly how much oxygen they need and their ability to tolerate the device. So the general principles are here. The choice is going to depend on the dose, right? Like if I need more FiO2 to be delivered, I'm probably not going to choose a nasal cannula. Like somebody in moderate respiratory distress is going to be different when I want to provide like high flow or BVM to them. Using a humidifier, if the oxygen is going to be prolonged, we can dry out the nasal mucosa pretty quickly, cause nosebleeds, and everybody in this town is on blood thinners. So it's not ideal. If we can humidify it, I don't know if that's an option for you guys in like your longer transports, but it's a good idea if we have that option, right? Monitoring with a pulse ox for effectiveness, and being able to either escalate or de-escalate. Not everybody needs 15 liters on a non-rebreather for a super long time, but you know, sometimes it's easier to de-escalate and then finally back to a nasal cannula. Put the patients in a position of comfort. This is really true for kids who are agitated, scared, older adults that just kind of want to sit forward in that tripod position. They can use all these devices however they're comfortable, and I think that that's appropriate too. You want to regularly monitor oxygen tanks. They fall, they can shoot apart like missiles, they can develop rapid leaks. Be careful with your oxygen tanks. They're actually they can be pretty dangerous weapons if you let them. And then finally, you want to titrate appropriately. If your patient doesn't need a non-rebreather, like we said, de-escalate. Continuously monitoring your patient will ensure that you're staying on top of this. And so let's talk about some of the devices and how they're used. So blood-wide, this is common, especially in kids and infants. It's definitely not a temporizing measure for agitated babies that won't wear it, but it's a good method for kids with reversible causes of respiratory distress, like croup, bronchospasm, etc. It's going to provide them a little bit more support than room air. And typically, they're like laying there breathing, and mom can hold it in front of their face, or you can, whatever. But it's super easy to do. You could even attach it to like a styrofoam cup or some other reservoir to get that kid like up to 10 liters of oxygen. Then you've got our most famous nasal cannula, our low flow nasal cannula. So much so that you can even like buy this multi-pack here on Amazon. That's actually where I got this picture. So anybody can buy one of these, but a traditional nasal cannula with adequate tubing can provide up to 4 to 6 liters of oxygen effectively, equating to like 37 to 45% of oxygen, a lot of which is going to be lost to the surrounding environment since it's not super invasive and doesn't have a really good mask over the face. But at 6 liters, you're pretty much maxed out. And if you need more, then you need to switch your device. But if we give too much oxygen, like I said, it's not going to warm it like a high flow device would. There's a risk of drying out the mucosa. You can use these in kids, and as we move into like flu, RSV season, these are going to be more popular for them. If you look at a lot of stats and research surrounding like high flow versus low flow, they'll tell you that basically the low flow device provides little benefit. But sometimes, and you guys know the best, that this is actually a really good device to provide some emotional and moral support to some of our patients. And so, you know, sometimes they just feel better even with a little bit on there. So I think it's actually a really underrated device, and, you know, we use them just a lot. Next thing we'll talk about is a simple oxygen mask. These are the low flow masks that'll give you variable oxygen percentages from 21 to 60%, usually at a rate from 6 to 10. The amount of oxygen they get will actually depend on the rate and depth of their respirations as well. So if they need more support in terms of their actual respirations, this isn't your mask, right? They're not going to get very much of it if they're not actively breathing with you. The mask contains small holes on the side to allow for exhaled air to exit the mask, which is what prevents suffocation. That'd be kind of poor form on our part, so we don't recommend it. You can use this for any patient who needs like a low to moderate amount of oxygen, like we discussed. Not quite enough for like a Venturi mask or like a high flow. And the disadvantages to this would be like obstruction and from access to the mouth, or like if they're vomiting or something. If it doesn't fit right, and some of our like older ladies have like these really tiny little faces, and we stick these on there, there's no way around it, but like the mask just covers their entire face. But it doesn't provide a consistent amount of oxygen, so you have to just keep that in mind. Next, we've got the Venturi mask, or the air entrainment mask. This provides preset oxygen to the patient using this jet mixing technique. So oxygen will get delivered at a higher velocity through the small orifice of the mask and through the adapters. Those are the colors that you see on the bottom. And as the percent of inspired oxygen increases using the mask, the air to oxygen ratio is going to decrease, which means that the maximum concentration of oxygen provided is about 40%. The benefit of this is that the oxygen level provided is constant to the patient regardless of their rate. So that's kind of a benefit over the simple mask and even a non-rebreather. The flow through the mask always exceeds minute ventilation, which is what prevents the entrainment of air around the mask and dilutes it. So the limitations of this one, again, are going to be the fact that it sits on the face. If you need more O2, you're going to need a different mask, and you've got to switch out your adapters potentially. And if it doesn't fit perfectly, again, your FiO2 can go straight out the window, and it doesn't matter what you're trying to give them. So you really have to make sure these masks fit well. Commonly, again, non-rebreathers is some mask with a bag attached to it known as the reservoir bag. The bag will draw in during inhalation to fill the mask in a one-way valve, or sometimes multiple valves, and features ports on the side for exhalation. And this results in an ability to provide the patient with 100% oxygen at a higher flow rate. The reservoir bag is an attachment to an oxygen administration device, obviously. And by allowing a collection of 100% O2 in the bag, the patient is going to receive a higher concentration of oxygen. That reduces the percentage of inhaled gas made up of atmospheric oxygen and makes sure that they get what's in the bag. These can provide anywhere from 60 to 91% of FiO2, up to 10 to 15 liters per minute, which is the highest that we've seen in all of our delivery devices so far. So the risks and limitations, again, include suffocation if they're not used properly, and kind of just, again, covering the face and the mouth. There's also these partial non-rebreather masks. I don't know if you guys have these as well, but they're the two-way valves as opposed to the one-way, so they don't completely prevent you from rebreathing the same air, but they can provide the same concentration of oxygen. This is a busy slide. I don't expect you guys to sit here and read it, but it's a good visual representation of understanding the difference between like your simple masks, your Venturi masks, and your face tents and all that kind of stuff. So it's kind of like a good image. I just got it from Google, but if you need to really understand them, like put them side by side so you can understand like which one does what and how much you can get through each one. High flow, I'm not sure that you guys carry this. Correct me if I'm wrong, but if you do, it's a great device to use. One, because we can 100% humidify the air that's delivered through the system, and two, we can deliver, and we do deliver, a higher percentage of FiO2 that goes in. You can give actually up to 60 liters per minute with these devices, with better delivery and less leakage of oxygen through the device. Here on the screen, I put some of the reasons why these devices are used commonly, but another one that's not there would be like kids in any respiratory distress. This can really help kids with their respiratory status for any reason, really way better than the low flows can. And they can really help improve their ventilation status. So it's something important to consider in kids. But the 5 major things that they think make these so efficient, and while it's not a requirement to know it per se, sometimes it helps you understand like why I'm choosing this delivery device over something else. One is that CO2 or waste gases will increase with physiologic dead space when people aren't breathing properly. And it's going to allow them to better move that air like throughout, like the bad stuff out and the good stuff in. It decreases a patient's respiratory rate. That's a big reason why we use it in kids. It provides some degree of PEEP, or that positive end expiratory pressure, acting similarly to CPAP without being a full CPAP machine. And so you get better alveolar recruitment, increased surface area for gas diffusion, that kind of stuff. You get increased tidal volumes for our patients, or the air they get per breath, and then increased end expiratory volume. So there's obviously some limitations to everything that we do. And one of the primary ones of this one is that it's really expensive to use. They're super complex. There's a risk of ineffective sealing. And so getting that air loss, like that leaking air, is going to take away that positive airway effect. And that's what we wanted in the first place. So I don't know that the risks are going to stop me from trying to use it on my kids, but it's just something to think about. So, of all the skills that we've talked about so far, and a lot of the skills by any emergency personnel, like us physicians and RTs and nursing staff included, this is one of the hardest skills to teach people who are performing airway management, especially if you're like me and you've got like a smaller set of hands than my 6'5", 300-pound husband, who does these mask skills like all day long, right? It's a very challenging technique. And so any chance that you get to practice is going to be super important. This can buy you a ton of time in the field when you're doing a code. I tell all my interns when they respond to codes on the floors, you can bag somebody all day long during a code. You can bag somebody all day long at any point, as long as you've got a good seal. And so that's why I say it's a really important skill to have. If you can't get an airway, just continue to bag them. Put in your oral airway and bag until you can get somewhere with some help. The 3 main factors for successful BVM use: patent airway, adequate mask seal, and proper ventilation, such as like rate and volume of the bag squeeze and things like that. And we'll talk about a little bit of these, but usually when I say like a patent airway, I'm throwing an OPA in to ensure patency, and then I'm using the BVM. Obviously, you can use an NPA, but it might be like a little bit more stuffy at the top of the mask. But it can improve ventilation when you use one of these devices in conjunction with the BVM. Okay, this is what your single-handed techniques look like. It's probably the most common for you guys in many instances because you don't have a ton of help in the back of your buses. But if you get an extra warm body, you've got a paramedic student, you've got somebody riding with you, your 2-handed technique is going to be your way to go. And your EC grip, noting your E along the 3rd through 4th fingers, pulling upwards on the mandible, your C grip being on the mask. And it's a delicate balance of pushing the mask down onto the face without pushing your hand down on your E grip on the jaw. So that's why I say it's a really hard technique, but making sure that the pressure you're applying is going to allow you to keep that airway open. For smaller hands, and those of you that are online that probably can't see me, if you take your E grip and you kind of move it around to the front of the mandible, and then you turn your C kind of facing you. I find that techniques for smaller hands is a little bit more helpful. And with anything, again, this takes a lot of practice. So if you can try next time you're bagging somebody, move that grip around to the front of the mask if you're by yourself, see if it works better, because you get a little bit more of your finger around the mask and you can still pull the jaw with a smaller hand. Two-handed technique is obviously ideal. It's more effective. Like I said, not always practical. But if you get lucky, the more experienced person actually should be holding the mask, and then the other person's going to be squeezing the bag. We have greater minute ventilations and tidal volumes in patients that we're doing the two-hand bag technique on. But again, it's going to be hard. Knowing how to do both methods is going to be important. So how do we troubleshoot our BVM, right? And it sounds silly, but when it's just not working, there's things that we can do to get better ventilation if we're already in a situation where we can't get a better airway. The first thing that you have to look at is inadequate mask seal. This can be due to a number of things: facial hair, loose false teeth, edentulous patients. If their false teeth are loose, take them out, put them back in, use a 4x4 to expand their cheeks, make more room in the oral cavity. KY jelly, you can reduce air leaks in people with facial hair actually, because it'll kind of stick a little better. These are just things that are going to kind of improve that mask seal, but that's usually the first problem that you want to address. And if you're having trouble ventilating, make sure the mask is the proper size and it fits well. And again, that airway adjunct, using something else with it. Head tilt, chin lift. Like I was saying, when I prepare for my intubations, and I know this is easier said than done, I'm doing a head tilt, chin lift. Somebody else is holding my bag, and now I've got a good airway, like a good patent airway that I'm adequately pre-oxygenating. This is also, we're going to kind of talk a little bit about non-invasive stuff. This is kind of a little bit of a busy slide when we talk about CPAP and BiPAP. The devices are going to provide positive pressure ventilation without being an invasive tube in the airway, and patients like that sometimes, and so do their families. The goal of non-invasive is to augment spontaneous respirators and is ideal for cooperative, awake, reflex intact individuals. We don't start it when they're agonal. We don't start it when they don't have a gag reflex. We don't start it when they're vomiting, altered facial trauma, nosebleeds, skull fractures, that kind of stuff. And you want to be careful even in hypotensive patients. Why is that? Because the volume depletion effects on the cardiac output can be worsened by this positive pressure. You can kind of go into like all the nuances of how it works, and for time purposes, it probably will not today, but this can reduce a patient's work of breathing by up to 60% in many cases, improve muscle endurance over spontaneous respirators. It's a really good way to buy patients some time when they're getting tired and we want to try to avoid intubation. And actually, there's a lot of disease processes that prefer this positive pressure ventilation by the mask rather than intubation. And you guys know a lot of these things, CHF, COPD, a lot of times we actually prefer this. Two advantages you see that I bolded at the bottom of the chart are something that don't make initiating like non-invasive positive pressure ventilation is super obvious, but the less risk of intubation and shorter hospital stays, like I said, are important to patients and their families, whether or not they're thinking about it, and it improves their hospital stay overall. So, not initiating and not going straight to the ET tube is actually going to be really beneficial for a lot of people. So definitely consider it. So why do we do it? Like we said, the most common uses are going to be cardiogenic pulmonary edema, our wet sounding, crackly, fluid overloaded CHF patients. We don't ever see any of those, right? But we talked about why this helps them in regards to opening up that pulmonary vasculature, decreasing venous return to the heart, and prevents overfilling of the right heart that backs up into the lungs, right? That's what it's for them. But in COPD patients who are really struggling, asthma exacerbations, that kind of stuff, you want to be careful in this population because they can get some air trapping and subsequent barotrauma. If they have bullous disease, that can be dangerous for them too. But the positive pressure through expiration can prevent that sometimes. And they blow off this extra CO2 and it allows them to move more oxygen through their lungs. So consider using this with your adjunctive medications, obviously like breathing treatments, your anticholinergic meds, your steroids, that kind of stuff, because this will have later effects on their respiratory status that's super helpful. And for both of the first two populations, they have decreased mortality rates and length of hospital stays, decreased risk of intubation. So always consider your non-invasive in these groups. It's sometimes the best help that you can really offer them. The last one is pneumonia. You don't always think about it because you don't want them blowing that like infectious air possibly into the the bus you guys are riding in. And they can be really hypotensive if they're super septic. So just be kind of cautious, but it can help the ones that are not like super duper sick. The differences between BiPAP and CPAP, we'll talk about very briefly. So CPAP is going to provide a constant positive pressure through the respiratory cycle. So it's like constantly living right up here. Patients can sit a bit more comfortably due to the lack of changes of the pressure. It's not as accommodating for respiratory changes in the first place. It's easier for them to sleep in. It's typically less expensive. This is a really good device for your sleep apnea patients. And then you have your BiPAP. Your BiPAP is going to have two different pressure settings, right? Like that bi-level pressure settings for inspiration and expiration. In expiration, the pressure is going to be a bit lower, and it's typically used for more complex diseases like CHF, COPD. And if you guys only carry CPAP, then we kind of switch them to BiPAP once they get there to us, just because of some of the nuances of how the device works, right? The benefit of having a lower expiratory pressure will allow the patient to feel as if they're not like fighting against the machine when they go to breathe out. And these can like auto adjust during the night when they're wearing it. So it's a bit more comfortable for the patient a lot of times. So if this is an option, it might be one you want to take. Complications with it. There's complications with everything that we do. I've said that multiple times. Difficulty with mask seal. They're not comfortable. Patients that are claustrophobic really hate this. Aspiration is actually a bit more rare than we thought, but every once in a while you go to check on your patient and she's like, I'm going to vomit. So it's time to take off this mask, right? Choose the right population to do this in. Air trapping, barotrauma, that'll present as like a pneumothorax or a severe pneumothorax. Hypotension, secondary to that decreased cardiac output. Abdominal compartment syndrome is one that we probably don't think about, but that air is not selective for just the airway, right? So it's over their nose and their mouth, and they're hypothetically breathing on their own. So you can get gastric distension, increased pressure within the belly. Not super intuitive, also not super common, but something to consider. Anxiety and agitation, again, we talk about this one a lot. A lot of our patients that are awake and alert and on these machines do require some type of like chemical assistance with this, whether it's like, like a low dose ketamine or Presidex or benzos, something that's going to allow them to continue to breathe on their own, but calms them down within the mask. I can tell you right now, I would hate to have that thing on my face all day long and all night. It's got to be a hard machine to wear. And then, like I said, the ultimate message is to just kind of watch out for some of these things as they come up. Next topic is going to be our supraglottic airways. These go into the mouth that allow for oxygenation and ventilation without the visualized insertion of a tube into the trachea. So it's a kind of a blind placement. They're not usually used for other reasons than to abridge to a definitive airway. And we can't put these in patients that have a gag reflex, right? So they shouldn't be used for the long term anyway. Studies have shown that the use of these in the field, like the ones that I showed you, actually improve cardiac arrest survival rates when they compare to ET tubes. So don't delay, throw any of these in, bag on your way to the department. And it actually has shown to have a lot of benefits. So the confirmation of these are also done by CO2 devices, but it's going to be a little bit different, obviously, than when you have an ET tube in place. So your eye gels, I don't know which ones of these you guys carry. I'm going to talk about a couple different ones. So hopefully at least one, at least one of these you guys carry. But you do carry this one? Yeah. Okay. So the eye gel has the soft cuff. It feels gel-like at the bottom. Go figure. And it seals the perilaryngeal structures without inflating any of the gel part. Why does this help? It limits tissue compression caused by some of the other devices that we have to inflate. Again, lube it up, advance it into the airway until you meet resistance. There's a lip line on the device, and when it correlates with the patient's lip, it's in place. Complications from something like this are typically infrequent, but can include laryngospasms and a sore throat. Eventually. I can't imagine your unconscious patient's going to be complaining about sore throat. Your King LTs is another option. This is a single lumen tube with a proximal cuff that seals off the posterior oral pharynx and a lower cuff that occludes the esophagus. Also placed blindly until the lip line is next to the lip of the patient. The balloons are inflated to about 60 centimeters of pressure. And then after it's placed, consider the thought of having to just kind of pull it back slightly so that way it fully occludes the esophagus. Complications of this are going to be tongue engorgement because you have that device in there and it impedes venous return of the tongue, which you don't always think about, but if it's going to be in place for a while, you've got to. And these generally work really, really well. Your LMAs, these are also placed blindly. The laryngeal mask airway occludes the structures around the larynx through that single inflated cuff that we talked about. And this is where you have to be careful pumping that cuff all the way up and leaving it in place for too long because it can cause some necrosis of that tissue. These are useful when the vocal cords can't be visualized during intubation, and successful placement is anywhere from 88 to 100% in the field. So that's a pretty good percentage. I'm going to run with that. There's also a number of models that really aid in like conversion to an ET tube, so it makes it easier. We don't always have to just like yank these out when you guys put them in. You've really helped do a lot of work by just putting these in. And then complications, again, include partial or complete obstructions, aspiration of gastric contents, a lot of kind of the same thing. But a lot of the data out there actually shows that it helps prevent aspiration, which is kind of interesting. That, again, was limited in my research. So And then a Shiley, I don't know if you guys have these or have used these before. I've only used one of them, and it's esophageal tracheal airway. It's a plastic double lumen tube, also blindly inserted. They kind of describe it as like the predecessor to the King LT, and it's used very frequently in many EMS locations. The proximal, more like low pressure cuff will seal the pharyngeal area, where the distal cuff is going to sit in the esophagus, and balloons inflate with up to 80 mLs of air in the proximal cuff and 10 ml in the distal cuff. The cool thing about the double port is that if it's in the esophagus or the trachea, the patient can still be ventilated. And so that's really cool. And there's no chest rise on one port. You just switch to the other port and see if that works. Hypothetically, it should work. I know we don't use a ton of these anymore. At least I don't see a ton of them, but they're kind of a cool device. Oh yeah, the combi tube, yeah. Yep. So like I was talking about a little bit before with the LMA, you want eventually the supraglottic's got to be transitioned to a more permanent airway. It typically is transitioned to an ET tube in our department, but fortunately it doesn't need to be done emergently. You can actually leave this guy in place, like if you're running a code and you've only got one provider or one person to intubate. It's not like always the first priority. If you're ventilating the patient through these things, leave them in place. But there's a couple different ways to do it. Obviously, you can just take that SGA out, perform direct laryngoscopy. You can convert it with a gum elastic bougie. So it's kind of considered a blind exchange, but you can pass the bougie through, slide it off, slide the ET tube on. Kind of nice because you don't have to manipulate that larynx. You can convert it with a fiber optic bronchoscope, which is kind of cool. We don't really use them a lot, and you probably don't have them in the field. However, the concept of it's pretty cool. The videos make it look super easy. And then, like I said, you can just leave the SGA in place. And if this is a patient that meets criteria for a surgical airway, once they get to us for any reason, we just leave them in place, go ahead and do it, and then you can take it out. So I think this is what a lot of people think when we talk about airway management. And like I said, it's the bread and butter of what we do. It's my favorite procedure. I love to do it. I also love to give it to people who are still learning because it's easy to explain once you kind of get the process in your head. And so we'll kind of talk just a bit about this today too. I'm not going to talk about this for a long time by any means because we just got this lecture, but I want to point out a few things that I consider when I'm talking about a difficult airway or thinking about a difficult airway. And they also kind of fall under the category of like difficult BVMs too. But obesity, no teeth, big beards, those are like the big ones that we see around here. So things to consider, but really anything that makes an airway adjunct, that allows you to put an airway adjunct are going to make an intubation more difficult. So if it's difficult for you to do the BVM, it's probably going to be difficult in some degree to do an intubation. So just try to get to the ED as fast as possible. But these are some of the things that I know that my husband talked about the other day. Okay, this is not a slide for you to sit here and read and memorize and do all these things. I show this to some of my trainees, my co-residents, my interns, my medical students, because you're only as successful as your preparation, right? And so these are all the things hypothetically in a perfect world you have at your disposal when you're doing an intubation, right? And who's checking for the tongue blades? Who's checking for the Crike kits? Who's checking for the McGill forceps? Not necessarily, but sometimes it's important to know that those are things that you can use in order to be successful. So you need to have the basic stuff, but there's a lot of extra stuff too that we don't think about. And so, you know, like you guys do some of like this really cool, like MacGyver-y, super talented stuff in the field sometimes. And I was like, I don't even know how they did that, but it worked and we're going to run with it. And so, you know, like in the hospital setting, we've got all of this and typically it's in a cart. And so that's really nice. But these are just some things to think about, that's all the equipment you hypothetically need for an intubation. So I just mentioned pre-oxygenation, and like we know that that's important. Studies have shown that 15% of initial emergency airway attempts are going to fail and 3% go straight to an ET tube. But those numbers aren't too bad. When you're doing an airway assessment, even when they look like the ideal anatomical model here on our left side, you can always anticipate the guy on the right. Like always anticipate that he's going to have no neck, no jaw, he's super big, and maybe he's got no teeth in there. Like you always want to anticipate that it's going to be difficult. Consideration of pre-oxygenation, though, is the most important thing in that part you can't skip, even if it's going to be an easy airway. When patients have an O2 saturation of less than 70%, they have an increased risk of decompensation that's really, really fast. They'll turn from 70 to like 30 in no time, and next thing you know, their heart's not beating anymore. And so you want to be careful about that. The role of pre-oxygenation, like we had talked about, is to displace nitrogen from the alveoli, to decrease the chance of hypoxia. Safe apnea time is the period in which you're pre-oxygenating is going to be a lot shorter in your cases. So the better job that you can do with the BVM, maybe even a hope and a prayer, is going to be important. If you don't have a spontaneously breathing patient, you'll do this part with a BVM though. So if you can get patients to like 95%, it's okay to just go ahead and try. But, you know, something that you guys, I don't know if you guys carry ketamine, but that would be something that you can also give to them to sedate them that allows them to keep any kind of respiratory drive to optimize your pre-oxygenation. So this is a hot topic as well, RSI, known as rapid sequence intubation. Like, do we do it? Do we not do it? It's a sequential administration of both a sedative agent and then a paralytic. As you see here, the goal is to allow for the rapid placement of the ET tube beneath the glottis to secure the airway. In properly selected cases, of course, not everybody's going to qualify. It's very superior to sedation alone, and it's typically the method of choice that we use in the field and in the department for those who are comatose, arrested, etc. You don't actually need it for those patients, but it's possible that you might if they still have a gag reflex. This can be a total lecture in and of itself, and I'm happy to come back and do that at any time because there's so many nuances to these meds. But I listed some of the common ones here that you guys use, that we use. It's all kind of similar. So just being familiar with your drugs, like not using succinylcholine in a burn patient or a renal patient, like those are some considerations you've got to make. And like I said, it's a whole lecture in and of itself. We would not use RSI drugs actually in certain cases. Cases in which muscle relaxation would not improve any laryngeal edema is one of them. Anticipated difficult airway cases, because once you paralyze them, there's really no going back until it wears off. Because I know you guys probably don't carry like reversal agents on your buses. And so, you know, just being really cautious, like what can I do to optimize the patient just in my transport to the ED? So again, it's like one of those controversial things. And it's a whole lecture in and of itself. All right, well, in my next life, I'm probably going to be more technologically savvy because these pictures are kind of boring. Like, I sit here and explain intubations all day long. A video probably would have been a little bit more beneficial. Hypothetically, though, you guys kind of all know of these things, but we'll just kind of talk about, like, how to do an intubation. I had the privilege of rotating in an anesthesia department prior to like being an intern. And so I got to do tons of intubations and it was really enjoyable for me, which I think is why I like it so much. Learning in an OR, I know that some of your paramedic students will go there. And so it's really awesome to be in a controlled environment where they can learn these easy intubations. And there's nothing ideal about every intubation, but it's ideal to know what you're looking for, right? I know that Dylan talked a lot about like preparation and ramping up your patients, getting them in the right position. You guys don't have that luxury all the time. And so, you know, I can say put a shoulder bump under kids and obese patients, but meanwhile, you're just, like I said, trying to MacGyver some stuff out there and get your tube in place. So what does ideal position look like? It doesn't have one for you guys, and that's okay. We can talk about it all we want to, but aligning the external auditory canal with the sternal notch is kind of the best view that you're going to get, especially if they don't have a cervical collar on. But, you know, I've intubated vomiting patients sitting upright like this in the ICU. And so however you can get that tube in is okay. Some big things, clearing the oropharynx is one of the biggest things. Removing dentures, obscuring blood and vomitus with your suction. If you can't see, you're not going to get it in there. And if you goose it, that's fine. Leave it in there, suction out, try again. But again, you know, like it's obviously a nerve-wracking situation when your patient doesn't have an airway, their O2 sats are dropping. Now you've got a tube in there. It's obviously stressful, but you want to do the best you can. Holding the laryngoscope closer to the blade is going to give you actually more range of motion at the wrist than you'd anticipate. And so that's something to consider. Holding the blade itself, like on the upright part of the blade, it's actually going to be a little bit more difficult. So consider sliding your hand down to the base of the handle along the blade, and that way you'll actually get more fine motor, like range of motion type skills when you go to manipulate it. And then when I try to explain this to medical students, when you go to scissor that patient's mouth open as far as you can on the back molars, if they've got molars, that is going to be your most important step. It's going to give you the best visualization of that blade going into the back of their throat. Just some of the important things, you know, you're not just like trying to jam it in there and get the tongue out of the way. If you can really open that jaw, it's going to provide you with better visualization. And then as I'm visualizing and lifting the epiglottis, with a Miller blade, you're going to go directly into it. And with a Mac, you're going to go like, you'll indirectly do this by lifting behind it. And this is actually what I mean by that. So knowing the importance, and like I said, typical dinner time conversations in our house are actually going to be, you know, like which one is better to use. You know, all I got to do is rile him up like this way. But here's a side-by-side comparison of them. And for time's sake, I'm not going to kind of like go through a lot of the details, but knowing where your blade's going to sit is important, because if you've got the Miller blade in the wrong place, you're not going to get that view right. And so like once you pass the ET tube through the cords, you'll inflate your balloon, check with your devices, like you've got a CO2 monitor, you've got a stethoscope, listen to breath sounds, check your monitor, and then just transport to the ED, however you guys are able to do that. Videos, do you guys carry these videos? You do have handheld videos? Yeah, these are awesome. And I think it's going to be only a matter of time before these become the standard of care in both the field and the hospital setting. It's a high resolution camera that allows for basically indirect glottic visualization through the camera. I love to use these. They're great teaching points. We just got new ones in the department that actually allow us to record them. And so I think if I, again, was more savvy, I probably could have put a recording of my last one in here. So it's a lot educational. It's a lot easier to perform your intubations. And the best way to confirm your placement is actually with direct visualization, and that allows for everybody to visualize it. And so they're actually really good devices to use. So definitely consider using them on your intubations. Blind nasotracheals. I haven't done a lot of these myself, but I do think that they're also an option if you need them. I don't know if this is part of your guys' scope. I can imagine it would be if you're allowed to do it through the oropharynx. It's helpful when laryngoscopy is difficult, when RSI is contraindicated, when fiber optics aren't available, and you just need to get an airway. The sniffing position is kind of where you'll put the patient, so the head slightly extended is ideal. And you can stand actually to the side of the patient and kind of just like squeeze it through their nose, almost in the same fashion that you're putting the NPA in. Obviously, the contraindications to this are going to be severe trauma to the nose, pharyngeal hemorrhages, avulsion of the nasal turbinates, intracranial placement, that sounds scary, and then vagal responses whenever you're putting anything back next to that vagal nerve. So things to keep in mind. Complications, again, this is a busy slide, and we don't always think of these things until they're kind of happening. Hypothetically, we know that patients become hypotensive after we RSI and intubate them. But, like a lot of it, it's going to involve quick recognition, possibly removing the tube if it's in the wrong place, pulling it back, like readjusting a dislodged tube. A main stem intubation, you probably realize when you only have like right-sided breath sounds, right? So pull the tube back. Aspirations, keep suctioning. I said before, if you goose it by accident, that's okay. Leave it in place. So now you know where your tube's got to go north when you're viewing the vocal cords. Hypotension, give fluids, maybe give pressors. There's ways to address all of these things, but keeping them in the forefront of your mind is going to be more important than trying to like backtrack through all of that. Again, you guys got a whole lecture on this, but there's two major types of intubation difficulties that we talk about are going to be anticipated, the ones that we can see, like, oh, this patient's obese, or they have crazy teeth, or they've got a small mouth. Like, those are the things that we can do. And then you have your other ones, which are unanticipated. Regardless, if it's unanticipated, especially after you've administered your sedative and your paralytic, one attempt or two attempts is enough to declare a difficult airway and prompt correction. Couple things that you can do, obviously stay calm. It's their emergency, it's not yours. Think clearly, communicate with others, and use your algorithms to determine the best step for you next. Call for help, call med control, call an ACLS bus, call MedFlight, call somebody, ask for help. This is not a time for you to be like, oh, my ego hurts because I couldn't get the airway. It's okay, we all mess up. I've goosed people too. So you want to just call for help. Get somebody who's more experienced in the room, and maybe somebody with more resources. Consider your next steps and just plan for them. You want to communicate those with clearly, like, I have a plan A, but what's plan B, C, D, E? Changing airway techniques with each attempt, doing the same thing over and over again is insanity, right? Like literally. And so, change your blade, change your tube size, change the operator, go to a glide scope, do something else, and that will help you. And then let your meds wear off is another option. Just keep bagging the patient. If you've got a student or somebody extra on your bus, head tilt, chin lift, jaw thrust, bag all the way to the department. That's okay. That's going to work. And then again, your non-invasive measures such as BVM. Again, don't panic. Sometimes this is what our brains look like when we get all nervous and our patient's crashing and we don't know what to do. But like I said, our unanticipated airway difficulties can make us feel like this. It shouldn't. Just take a breath. It's their emergency. Continue to bag until you get to the department. For time's sake, I don't really have, I've got content on surgical airways. I was going to talk about them a little bit. It's not even something that we do very often in the department. We've got surgical crikes for people over 12, and then your percutaneous crikes for kids under 12, typically done in traumatic situations. But again, key to successful airway is advanced planning and training. So like, even I'm not the first person in the room to go ahead and do a crike, right? If my attending's there, if my trauma surgeon's there, if somebody's there who's done a number of crikes, they're going to do the crike, and I'm just going to be kind of like there for comfort. Common approach, knife finger bougie. I'm cutting open the skin, spreading out the tissue, inserting the bougie, and hypothetically I can just insert the tube. The biggest thing that people worry about is obviously bleeding, but bleeding, the tamponading effect of the tube will actually help that. So kind of fight through it, use your suction. And I don't even know if you guys do these in the state of Missouri. It's just like kind of one of those things that's just cool to know. And then your percutaneous critics are done with your needle and a Seldinger technique. So they have the catheter over the needle and you kind of just poke through that membrane, especially in kids, and you can just slide the catheter over it. This one's really important. I don't want to just like run through this one. Again, ABCs over and over. Anytime you make a change, anytime you notice a change in your patient, the dope mnemonic is something that we teach in the hospital, especially for somebody who's been intubated. The tube can become displaced, obstructed. You might have caused a pneumothorax unintentionally, or your equipment might be failing. So consider those things before you just freak out and say it's not working, rip it out, do it again, still not working. Yeah, your patient's on oxygen because they have massive pneumothorax. And there's nothing you're going to do about that besides a needle chest decompression, and then you get to the ER. So you fix it. Just some things to think about. Transition of care, you guys do this really well. That's when you get to us, you give us a report. What did you do? What did you try? What didn't work? What did you give? All that kind of stuff. And so make sure you guys are just giving a good report. You guys do this really, really well. It helps us a lot because we're not questioning like, hey, the patient doesn't look neurologically intact. Well, you just gave rocuronium like 10 minutes ago. So, doing those kinds of things and, you don't overlook them very often and neither do we. So just kind of something interesting. This part, for time's sake, I had a really interesting study in here, but we'll just kind of skip forward to the questions. Essentially, the study point was to tell you that we don't actually have like a whole lot of information on EMS and airways. So if you guys don't have any questions, I got a really funny meme for you that my husband found, and it just makes me laugh because this is our patient population. But if you guys have questions, I'm happy to answer them. You can always reach out to me. I see a lot of you guys on the day-to-day. So thank you for having us back, and sorry for running over just a few minutes. Oh, no. Yeah, it's all good. Yeah. Oh, yeah, no worries. Thank you, guys. Yeah. No, all good.
Usually 20 to 30 seconds or so. Good stuff.
Yeah, hopefully it was helpful. Hopefully you guys learned something after all of your lectures and getting the what should have been first, right? Next year we'll plan for that.